Chapter 3. Pharmacological Interventions. Methadone is one of the primary medications used in opioid substitution therapy and plays a vital role in both maintenance and detoxification strategies for people with opioid dependence. Its use in primary care settings has been supported by strong evidence demonstrating reductions in heroin-related deaths, criminal activity, and improvements in social functioning and overall health. Methadone is a full opioid agonist, meaning it activates opioid receptors in the brain in a way similar to heroin and morphine, but with a longer duration of action. This extended effect allows for once daily dosing, making it a convenient option for many patients. The goal of methadone treatment is to stabilize the individual, eliminate the need for illicit opioid use, and provide a structured foundation for broader recovery work. When initiating methadone treatment, clinicians must adopt a cautious and structured approach. Starting doses should typically range from 10 to 30 milligrams daily. Depending on the individual's opioid tolerance, recent usage patterns, and any concurrent substance use, it is important not to exceed 30 milligrams as an initial dose due to the risk of respiratory depression, especially in those with low tolerance or uncertain substance use history. Methadone has a cumulative effect during the induction phase because of its long half-life. This means that with daily use, the drug builds up in the system, leading to a gradual increase in blood levels over several days. As such, dose titration should be done slowly and safely, generally not increasing by more than 10 milligrams every few days. The typical maintenance dose for most individuals lies between 60 and 120 milligrams daily, with some requiring more or less depending on their specific needs and response. One of the key considerations during methadone treatment is the risk of overdose, particularly during the induction period. This is especially critical if the patient continues to use illicit opioids like heroin alongside their prescribed methadone, or if they are concurrently using other sedatives such as benzodiazepines, alcohol, or gabapentinoids. These substances can have synergistic effects, significantly increasing the risk of respiratory depression and death. To address this risk, patients should be educated about the dangers of polydrug use and the importance of taking methadone exactly as prescribed. Providing take-home Naloxone kits and training patients and their families in their use is a vital harm reduction strategy. Naloxone is a life-saving opioid antagonist that can reverse opioid overdose if administered promptly. Its distribution is increasingly being integrated into OST programs as standard practice. In addition to clinical safety, there are legal considerations that both patients and clinicians must be aware of. Individuals receiving methadone and holding a UK driving license are legally required to inform the driver and vehicle licensing agency. The DVLA considers dependency on substances, including prescribed opioid treatments, to be a medical condition that may affect driving. However, patients on stable methadone treatment can often retain their driving privileges, provided they meet specific criteria and demonstrate safe, stable use. The clinician's role includes ensuring the patient understands this obligation, documenting discussions, and supporting any DVLA assessments if needed. Failure to notify the DVLA can have legal repercussions, particularly if the individual is involved in a driving incident. Methadone maintenance treatment is not solely about prescribing medication. It must be integrated into a comprehensive care plan that includes regular reviews, psychosocial support, and coordination with other services. The decision to start, adjust, or stop methadone must always be collaborative, based on shared decision-making between the patient and the care team. This includes monitoring not just for effectiveness in reducing illicit opioid use, but also for broader health indicators such as liver function, mental health status, and engagement with rehabilitation or employment support services. It is also essential to be vigilant for signs of diversion where prescribed methadone is sold or given to others. While suspicion alone should not automatically lead to discontinuation, it should prompt further investigation, potential changes to dispensing arrangements, and a reassessment of the individual's treatment plan. In summary, methadone is a powerful and effective tool in opioid substitution therapy, but it must be used with care. Safe prescribing practices, close monitoring, patient education, and adherence to legal requirements are all fundamental to successful outcomes. When delivered in the context of a holistic and multidisciplinary care plan, methadone can help transform lives and contribute significantly to recovery from opioid dependence. Chapter 4: Pharmacological Interventions. Buprenorphine. Buprenorphine is another cornerstone medication in opioid substitution therapy, offering a distinct pharmacological profile compared to methadone. As a partial opioid agonist, buprenorphine activates the opioid receptors in the brain, but to a much lesser extent than full agonists like methadone or heroin. This partial agonist activity provides a ceiling effect that reduces the risk of overdose, making it generally safer, especially in situations involving accidental or deliberate overuse. One of the most beneficial aspects of buprenorphine is its ability to block the euphoric effects of additional opioid use. At adequate doses, it effectively occupies the brain's opioid receptors, thereby preventing illicit opioids from producing their desired effects. This can reduce the incentive to continue using heroin or other opioids, supporting recovery and stabilization. Buprenorphine is available in various formulations, including sublingual tablets or films with or without naloxone. When combined with naloxone, an opioid antagonist, the product is designed to deter misuse. If the combination product is injected, the naloxone becomes active and can precipitate withdrawal symptoms. When taken as directed, the naloxone remains inactive. This approach reduces the likelihood of intravenous misuse while preserving the therapeutic benefits of buprenorphine. A key clinical challenge with buprenorphine is the risk of precipitated withdrawal. Because of its high affinity for opioid receptors, buprenorphine can displace other opioids from the receptors, leading to sudden and severe withdrawal symptoms if given too soon after other opioids, like heroin or methadone. Therefore, proper timing is essential when initiating buprenorphine, particularly for patients transitioning from methadone. A minimum of 24 to 36 hours is typically recommended after the last methadone dose, depending on the patient's clinical presentation and methadone dosage. In terms of administration, new long-acting injectable formulations of buprenorphine are also available and increasingly used in practice. These depot injections offer the benefit of sustained release over a week or even a month, enhancing treatment, adherence, and convenience. They may be particularly helpful for individuals who struggle with daily medication adherence or are at risk of diversion or instability. Despite its strong safety profile, caution is still required when prescribing buprenorphine in individuals who use other sedatives, such as benzodiazepines, alcohol, or gabapentinoids. While the overdose risk is lower than methadone, combining central nervous system depressants can still result in dangerous respiratory depression. Clinicians should thoroughly assess concurrent substance use and counsel patients on the increased risks. Buprenorphine, like methadone, should be part of a comprehensive treatment approach. Psychosocial interventions, regular monitoring, and multidisciplinary care planning remain essential. Shared decision-making is critical when determining whether buprenorphine is the appropriate medication. Taking into account the individual's history, preferences, and treatment goals. In summary, buprenorphine is a highly effective and safer alternative to methadone for many patients. Its unique properties, including the ceiling effect, reduced overdose risk, and formulation versatility, make it a valuable option in OST. However, successful outcomes depend on careful induction practices, awareness of polydrug use, and integration into a wider framework of support and recovery-focused care.